Everyone, and welcome to today's webinar, Hepatitis C Screening, Opportunities and Challenges in U.S. Emergency Departments. My name is Ryan Clary, and I'm the Executive Director of the National Viral Hepatitis Roundtable. Thank you for taking the time to participate today. For those new to NVHR, we are a national coalition of over 300 organizations working to fight against the hepatitis B and C epidemics in the United States. I encourage you to visit our website, www.nvhr.org, and consider joining your organization if not already a member, or by signing up for our listserv as an individual. You can go to www.nvhr.org/join for more information. Today I'd like to go over some housekeeping. This webinar is being recorded. And the webinar recording will be made available to everyone who registered and will be on our website at nvhr.org. All lines are muted to eliminate background noise. You may submit questions at any time during the webinar using the chat function or by emailing Tina Broder, NVHR, at tbroder@nvhr.org. That's tbrod@nvhr.org. We will have a question and answer period following all of the presentations. Today, we will hear from 4 emergency medicine physicians who will discuss their work implementing hepatitis C screening initiatives, institutions, as well as targeted versus universal screening and the challenges of sustaining such screening programs. I would like to personally thank all of our panelists for their leadership and to ensure that people are aware of their hepatitis C status, life-saving care and treatment, and for taking time today to share their experiences and their expertise. I will provide a biography for each speaker before their presentation. Our first speaker today is Dr. Rich Rothman. Dr. Rothman is a professor and vice chair for the Department of Emergency Medicine at Johns Hopkins University and holds a joint appointment in the Department of Medicine Division of Infectious Diseases. Dr. Rothman's research program focuses on the interface of emergency and infectious disease surveillance, diagnosis, and treatment. He has Dr. Rothman co-founded the Department National Consortium for HIV Testing in 2007 with colleagues from Denver Health, University of Cincinnati, and University of California at San Francisco Highland Medical Center, and is working with Dr. at the University of Alabama on expanding that consortium to advance hepatitis C linkage goals. Dr. Rothman currently directs the HIV hepatitis C screening at the Johns Hopkins Hospital. Thank you, Dr. Rothman.
Thank you, and just on the introductory, you can see the overall goal for our session and the name of our other speakers. So the presentation we have today is broken into 4 sections that you can see here, each one handled by a member of the team, and we're going to have time for questions and answers. I'll be speaking briefly about some of the background and rationale for HCV testing. This will be followed by Shay, then followed by Dr. Galbraith, and next slide, please. So, reminder for frame setting. We all know he is a contagious infection caused by a RNA virus. In terms of transmission, the most common route of transmission is by blood from an infected person, and prior to the early 90s, most of the transmission occurred via blood transfusion or organ transplantation, but that epi changed after recognition of the importance of screening the blood supply, and now the current primary mode of transmission is via needles and equipment from intravenous drug users, and I've listed some of the other common routes of transmission that most are probably familiar with. Next slide. So what occurs in hepatitis C is important from some of the issues associated with screening, which we'll be focusing most of the talk on, which is that, in some individuals there can be a brief acute illness right after, but then for the majority of patients, the acute is followed by a chronic long-term infection, and you can see on the side in terms of percentage of individuals who end up with each of the different stages of disease. For the majority of patients, there's a long-term chronic infection, and then for a small significant minority, there are potential long-term serious problems, principally on the liver, including cirrhosis, liver cancer, and death, and that can take a number of years to occur over an individual's lifetime. Next slide. It's also important to understand the overall impact of the disease in terms of both world global health as well as what we're seeing locally in the U.S. So worldwide, you can see a significant number of individuals have chronic infection and very high numbers of HCV-related deaths, attributable HCV-related deaths per year. In the U.S., 5 million currently infected with chronic hepatitis C, and somewhere around 15,000, probably a little bit higher, of HCV-related deaths. And you can see on the right lower figure that if you look at the incidence over time, you see this drop in incidence, which is number of new cases of hepatitis C each year that occurred after effective screening of the blood supply. But then more recently, we see a concerning increase, a rise related principally to the ongoing and emerging epidemics of intravenous drug users. One important point to note is, although we understand a lot about the epidemiology, some of the information about epidemiology in relation to screening is not completely good, and we're learning more about it currently. But from a screening standpoint, about 50% of the population who are infected remain unaware of their positive status. Next slide. Another just important frame-setting point to recognize, if you look at this recent, which was published in Clinical Infectious Disease this past year by Lin et al., the burden of hepatitis C in relation to other notifiable infectious diseases is highly significant. And if you add up all of the other reportable infectious diseases, and this was a list of about 60 other infectious diseases, including HIV and tuberculosis, hepatitis C now surpasses all of those. So importance in terms of a public health issue that we need. Next slide. The good news in terms of control and treatment that I'm sure many in the audience are familiar with is the efficacy of therapeutics, which can cure even more than 90% of persons who are infected and prevent long-term complications, including liver cancer, cirrhosis, and death. The practical challenge is the characteristics of the disease, that it's an indolent, meaning a clinically silent disease for most of the infected individuals' life early on during infection, and that we're still in the early phases of figuring out what the optimal systems are for screening and treatment of this significant part of the population. And also, as with any other public health and clinical issue, there are resource constraints that must be taken into account in trying to address that challenge. And some of those are particularly relevant for figuring out role of emergency departments. Next slide, please. So this is just a reminder of the current screening recommendations from the CDC, and you can see the copy of the MMWR report here, which came out in 2012, which took the prior targeted screening criteria, which are listed up at the top, and added on the birth cohort, which are individuals born between 45 and 65, recognizing that a significant proportion of those infected, about 75% of those infected, fall into that cohort, so that would be an important strategy in terms of single once-in-lifetime screening for that cohort, in addition to ongoing screening for those considered at risk. But what we're going to be talking about going forward is like how is that strategy rolling out, and what is the role of emergency departments as part of that strategy. Next slide, please. Why emergency departments? What's the role of emergency medicine as part of the public health system? So the picture up at the top right just gives you a picture of the volumes of individuals that are seen in emergency departments across the United States, and the trend's very easy to identify, which is ever-increasing number of visits to U.S. emergency departments every year, and it's now well over 140 million visits per year, and a significant proportion of patients visit emergency departments as part of their services at least once per year. And whether or not that's the most efficacious way for taking care of patients or not is not the subject of this discussion, but more of saying that this is a resource that could potentially be leveraged to help address some of the issues associated with screening, linkage, and treatment for those with hepatitis C. There is lots of controversy and discussion around how this can happen, and our other panelists will be speaking about this, but I just cited one of many studies that have been published about the role of emergency departments in public health related endeavors. And just to point out that there is a recent and probably about 15 to 20 years of track record of emergency departments having an important role in bringing about public health interventions for improving clinical care as well as the health of the population. That's challenged by increasing demand and increasing volumes of patients who are seen in emergency departments, and the primary mission that emergency departments have of taking care of the acutely ill. Next slide, please. One of the arguments that is made for emergency departments having a role in screening for, particularly for indolent infectious diseases, is shown here, which is that many of the patients who are coming to our doors for care are exactly those individuals who are at highest risk for unrecognized HIV and HCV based on epidemiologic characteristics of that population. We see higher rates of uninsured, higher rates of Medicaid recipients, as well as higher rates of minority populations relative to other sectors of the population of the healthcare system. Many of those individuals end up coming to our doors for primary care. And you can see on the right side as well, if you look at HIV potentially as a proxy for some of the issues associated with Hep C as well, that income level is inversely related to annual income. And so some of those trends in terms of the population we're seeing may be important to consider when identifying this as an important venue for screening. Next slide. So we asked the question of, like, can emergency departments be part of the solution? And my colleagues and I have had a number of years of experience in the realm of HCV screening in emergency departments. And I just referenced a full supplement to Annals of Emergency Medicine that was published in 2011, where we described some of the issues and challenges associated with bringing screening programs for an indolent infectious disease into the emergency department. And we talked about process and models, some of the regulatory and ethical issues, as well as some of the potential impact and outcomes which could be seen from bringing this type of intervention into acute and episodic care settings. There are numerous examples of success that have been realized even since 2011 in the past 5 years. And if you do any searches in the general medical literature, you can see a large number of projects and implementation programs with significant scale up of HIV testing as part of an integrated system in the emergency department for identifying those with unrecognized HIV. And I just referenced on the right panel a recent study that was published by Dr. Shay, myself, and other colleagues here at Hopkins that just described some of our experiences in understanding the epidemiology of HIV in our own emergency department, where we've had testing going on for more than a decade as part of an integrated process in the emergency department. And you can see over time with our program, and although all of the findings aren't completely attributable to the existence of an emergency department screening program, but there have been significant drops in HIV incidence in the Hopkins Emergency Department, as well as a significant increase in the rates of HIV viral suppression among those who are infected, pointing at the potential value of this testing intervention in the emergency department. Next slide, please. So just for frame setting for the rest of the discussion, in terms of similarities between HIV and Hep C, there are fairly many similarities. They're both silent, indolent, infectious diseases, often under-recognized by providers. The stigmatization associated with each of these diseases, although there are some variations in that stigmatization that may impact how to get the program in place. Both have significant morbidity and mortality, and there is some evidence that screening can have an important clinical and public health impact. Next slide. Some of the differences and variation will be discussed in the coming presentations, but each of these has some tie-in with a clinical care mission we have for our patients. For HIV, we've already demonstrated that emergency departments around the country can effectively screen large numbers of patients. Programs have already been established where these are integrated with routine care, and over the past 5 years particularly, there have been systems that have built in that have established the evidence for reimbursement and sustainability. For HCV, we're really more in the earlier phases of trying to see how this will fit in with our emergency department care. So just as to the next talks, I think that there's ongoing research that's required to better understand the epidemiology of the disease, to understand how to best develop screening programs that would make sense. Some of the diagnostic algorithms associated with testing are distinct from HIV. It can be complex, and so these will need to be considered. But some of the data that Dr. Galbraith and White will shows early evidence of what can be achieved. But the other important point to recognize is that this will need to be an ongoing dialogue and partnership between those involved in policy and implementation to lead to success. So I'm now going to return it over to Dr. Shay, who's going to describe some of the important work that will help set the stage for approaches to screening and populations, decisions about which populations to screen. Dr. Shay?
Great. Thank you, Dr. Ruffman. I will give a brief bio of Dr. Shay. So our next speaker is Dr. Yosheng Shay. Dr. Shay is an Associate Professor of Emergency Medicine at Johns Hopkins University School of Medicine. Dr. Shay's research work focuses on infectious diseases in the acute care setting, especially in the field of HIV and hepatitis C. His research work addresses emergency department-based rapid HIV screening and linkage to care programs, and he has published extensively in these areas. Dr. Shay's expertise in emergency department-based hepatitis C and HIV screening and linkage to care programs has led to invitations to serve as a panelist in the national HIV and hepatitis C conferences. Dr. Shay currently oversees and disseminates program outcomes of the HIV hepatitis C screening program at the Johns Hopkins Hospital with Dr. Rothman. Dr. Shay, thank you.
Hi, thanks, Brian, for your introduction. Next slide, please. So, CDC recommends HCV-based plus first cohort screening, and U.S. Preventive Service Task Force recommends for HCV screening too. So should we do this in ED? If we do, does CDC make the right call for the right target population for screening in the ED? The rationale of unsureness is that, first, current studies in the late 80s to early 90s all demonstrate high seroprevalence of HCV infection in ED population, close to about 20%. Second, a recent retrospective study on 2 concurrent studies in patients with any drug misuse by merchant in Rhode Island showed that the risk-based targeted plus first screening alone will miss about 50% of infected patients. Next. So what should we do? I know at Hopkins, based on our Baltimore City HCV epidemiology and our data in the 90s, we know that we definitely should implement an HCV screening program in our Hopkins ED. So we conducted a seroprevalence study to determine the overall burden of undocumented HCV infection at Hopkins. At the same time, we used this data to evaluate 2 stations, especially in birth cohort testing. Next. During the 8 weeks, we used West blood specimen to conduct a cross-sectional identity and link seroprevalence study in the summer of 2013. First, we stored the waste blood specimens from the ED patient in the freezer. At the same time, and obtained data from EMR database to retrieve social demographic and HCV-related information. The data were identified after completion of chart review. Then the research lab performed HCV testing. Laboratory testing result data then were merged with chart review data. In this study, undocumented HCV infection was operationally defined as presence of anti-HCV in the absence of HCV infection in the chart. Next. So during the 8-week study period, we identified more than 4,700 unique ED patients at our Hopkins ED. Among them, about 14% of them have anti-HCV antibody present. Among those 652 anti-HCV positive ED patients, about a third of them were undocumented HCV infection. Next. Let's see the prevalence of anti-HCV antibody. This figure shows that, as expected, prevalence of anti-HCV prevalence of anti-HCV antibody was higher in those age 45 before, male and Black race. Next. Also, as expected, the prevalence of HCV was much higher in those patients with HIV infection, patients who use injection drug, and those patients born in the birth cohort. Next. So this slide shows about the proportion of undocumented HCV infection. The proportion of undocumented HCV infection range from 25% to 50%. You can see that non-Black patients in both genders have higher proportion of undocumented HCV infection regardless of birth cohort or not. Next. If we further look down to age, race, and sex group specifically, we can see that this slide shows that baby boomer cohort has much higher HCV prevalence rate. However, you can see that for those after 65, also have high undocumented HCV infection rate, especially those aged 35 to 46 years old, or they were born between about 1966 to 78. Or you can see that for those non-Black males born after 65, all they have higher anti-HCV positive rate, much higher than the CDC recommendations set up about 3% threshold. Next. And this pie chart shows you that what will happen if we apply the 2012 CDC revised recommendations. Risk-based testing using HIV or IDU information will identify 26% of unknown HCV infection. You can see top upper left pie. And you also can see on the right side, first cohort testing could augment the identification of unknown HCV infection in our ED. This method could 49% of total unknown infection. However, you can see that on the lower left corner, 25% of unknown cases. Next. So in conclusion, our seroprevalence data show that our Hopkins ED has high HCV burden in our ED patient population. So we should implement an HCV screening program and use the one-time birth cohort testing will increase number of unknown and increase the identification documented HCV infection to 4 more. However, using the current 2012 CDC recommendation, we will miss 25% of undiagnosed HCV infection. Therefore, we should thinking about some modification of current CDC recommendation in the ED setting. And based on our seroprevalence data, we have implemented a non-targeted HCV screening program to test all adult ED patients unless they are known HCV positive or have been tested for HCV in our institution. Jim will include the Hopkins data in his presentation. Thank you. Ryan?
Great. Thank you very much. Our next speaker is Dr. Jim Galbraith. Dr. Galbraith joined the University of Alabama at Birmingham Emergency Medicine faculty in 2008 as the Assistant Residency Director and Medical Student Clerkship Director. In 2011, through funding from the Alabama Department of Public Health, DC, led the implementation of non-targeted opt-out HIV screening. In the first 4 years, this HIV screening program screened over 65,000 individuals and identified over 350 HIV infections. Leveraging the infrastructure developed for systematic HIV screening, Dr. Galbraith initiated targeted hepatitis C screening and linkage to care in the UAB Emergency Department in 2013. In the first 2 years, this program identified over 1,500 previously unrecognized hepatitis C infections and a high 11.5% prevalence of HCV infections among previously unaware baby boomers. Most recently, this ED hepatitis C screening program has expanded to a universal or non-targeted opt-out test in efforts to raise hepatitis C awareness and access to cure for a growing epidemic of HCV infections among young injection drug users. Thank you, Dr. Galbraith.
All right, thank you, Ryan, for the introduction. I have the pleasure of presenting the outcomes from our prospective ED HCV testing program, which includes data from some of our other panelist sites. Next slide, please. So what has been done in US EDs to date, mostly targeted screening, and as you'll see from this table, irregardless of the study or screening design, US EDs have consistently identified a high prevalence of hepatitis C infection amongst ED visitors. Even some of the early blind seroprevalence studies from the 90s and 2000s have revealed rates approaching 18%, and more recent reports from our targeted prospective screening have revealed antibody prevalence rates of around 10%. So that's 1 out of every 10 ED visitors. I'm going to talk about 2 of these studies, my own and Dr. White's, shortly. Next slide, please. To frame this, I'll explain briefly our integrated models of testing, which will generalize the methods for all of the presented results from Hopkins, UAB, and Highland Hospital in Oakland. All of us have subtle iterations or differences in our programs, but this is just to be a framework. So first, what is integrated testing? It basically means not separate. So instead of a freestanding booth or a single testing person that does the recruitment, testing, and post-test counseling, our testing is performed within the routine medical care provided as an emergency medicine service. So that means there are many of us that share in the burden of the process. So it's not just one person that's doing all of the testing, engagement, and subsequent counseling. So this will include physicians, nurses, laboratory staff, linkage to care coordinators, and sometimes emergency department technicians. The first step of the process is engagement. This mostly happens by nursing staff, also sometimes by ED providers. Most patients are engaged at triage, or what is the front desk of the ED on their arrival, or they're engaged at when they arrive to an emergency department bed. Most of the hospitals are using electronic health record prompts to prompt physicians and or nurses to ask about hepatitis C status amongst the patients, as well as to prompt an opt-in or opt-out test offering. The electronic health records also used to record the patient responses. Most are using automation to automate orders based on these responses. Once an order is placed and the patient has blood work performed, testing is performed in hospital labs on using an instrument. Many of us are using the Abbott Architect instrument currently. All of this is done with the goal of having the HCV antibody test result back during the ED visit. When it's back during the ED visit, post-test counseling for hepatitis C positive individuals is performed by ED providers, and simultaneously RNA is collected from the patient for HCV confirmation, which usually happens a couple of days after the visit. We all use linkage coordinators, contact with all of our HCV antibody positive patients to assist with linkage to care, and which includes primary care and assistance getting to an HCV treatment prescriber, as well as giving the confirmatory RNA result to the patient. Next slide, please. So our early work at UAB started in 2013 with targeted hepatitis C testing. Our targets were populations that included the baby boomer population, injection drug users that was current injection drug use or ever having used injection drugs, new diagnoses of HIV infection, or any patients with new symptoms of liver disease. And as I'll show later, we mostly tested baby boomers, where we identified a high antibody prevalence of 12% amongst those self-reporting no prior history of HCV infection. Most striking in what you can see in the figure was the high prevalence, which approaches 17% amongst the uninsured and underinsured individuals. And it was these findings that gained national attention in early 2014 as we had the newly released direct-acting agents hit the market. Next slide. Dr. White, who you will hear from after me, took this a step further, performing targeted screening in the Highland Hospital Emergency Department in Oakland, California. He confirmed similar findings to what we saw at UAB with a high prevalence among baby boomers. His prevalence was 13.7%. But he also identified a high prevalence among self-reported injection drug users of 39% and persons born after 1965, where he found a prevalence of 6.1%. Though not by design, this younger cohort, many were incidentally offered testing by nurses without any risk indications present, and still yet a very high antibody prevalence. I'd highlight in his the data that he presents in this manuscript that he overall identified approximately 750 individuals that self-reported injection drug use and was able to test 55 of them with a high antibody prevalence. What's not shown there, though, is that it was challenging to engage that population, and again, the majority were not tested in the ED, mostly because a large number of them declined testing. So it worked, but it was felt to have perhaps maybe fallen a little bit short of identifying and testing the majority of a target population. Next slide. And we saw the exact same thing at UAB. Our experience with targeted testing pragmatically missed the mark for identifying the injection drug using population. The bottom line is identifying non-baby boomer targets is very challenging. Through our screening program with targeted testing, 85% of the persons tested were baby boomers or older here at UAB. Persons who reported injection drug using risk and were screened for that purpose accounted for less than 5% of all test orders. And we also saw that we had some incidental tests of persons born after 1965 without any documented risk factors and found a 10% antibody prevalence. So the question is, why is this so challenging? I don't think it will be surprising to many of those in our audience here that stigma is a large barrier for providers asking, that this providers includes both physicians and nurses, depending on the reason for the emergency department presentation. Many are not comfortable asking injection drug use behavior questions, and for patients, recall bias and privacy is certainly a concern. And due to this, we may miss a large number of hepatitis C infections and an opportunity for engagement. Next slide, please. Leveraging our lessons overcoming stigma, barriers associated with HIV testing in the emergency department, we all initiated universal hepatitis C testing in late 2015. This is our general eligibility. It varies a little bit by site. In general, we're testing persons born after 1944 and those that are older than 13, or at UAB, we're testing individuals that are older than 18 years of age. Patients obviously have to be medically and surgically stable to undergo some of the hepatitis C status questions that's performed by a physician or a nurse, have reported no prior history of HCV, and have no prior test result in the electronic health record. Next slide. On implementation at UAB, which occurred September 15th of 2015, when we went live with universal screening, we immediately saw a threefold increase in the daily HCV testing rates. That's seen there in the figure on the left. Additionally, we increase in the proportion of persons tested that were born after 1965. Previously, that accounted for about 15% of our population tested, and now we were largely testing individuals that were in this younger cohort, who now account for about 65% of the population tested. Next slide. Here are our collective outcomes by site. For universal testing, you can see the time period for these reports and each of the sites in the columns. Together, what I'd like to highlight is what's in bold and in red in that third row, where we identified together a high overall prevalence of hepatitis C antibody reactivity ranging from 6 to 8%. Again, this is for all adult ED visitors without risk, any risk considered in the test offering. We also identify similar baby boomer prevalence there in the fourth row at all 4 sites, 10.5% at UAB, 14% at Highland, and 14% at Hopkins. And we're also seeing a high antibody prevalence amongst this younger cohort of persons born after 1965, between 3 and 6% overall. Next slide, please. The most striking finding is the prevalence by birth cohort and by race. So for the baby boomer birth cohort, at all sites we see disproportionately high rates among African Americans, somewhere antibody prevalence ranges between 12 and 20%, and what you can see in the red bold in the third row. For this younger cohort, though, this disparity flips, and we see prevalence rates highest amongst the white population, 12% at UAB, and we see 10% antibody prevalence for males at Hopkins and 7% antibody prevalence for females at Hopkins. And this shouldn't be that surprising given that this younger white population matches the demographics of those individuals driving the injection drug use and heroin epidemic currently. Next slide, please. So in closing of my presentation, I wanted to spend 2 minutes talking about some of the major implications of universal testing in emergency departments. Aside from us doubling the numbers of persons identified, one of the major implications of our universal testing is the identification of this younger second wave of hepatitis C infection, which is responsible for the new or incident infections that are occurring. So this identification in the ED allows for an opportunity for an intervention to reduce transmission amongst this population, and also with treatment could potentially play a role in national eradication efforts. Next slide. For our public health audience, EDs have tremendous surveillance potential. We have a high volume of unique visitors. We're well positioned to identify the disproportionately affected and hard to reach population, especially the IDU population. A lot of our urban EDs have a very wide geographic reach, and what we've been able to show in a previous publication, we actually have a sizable enough hepatitis C yield that allows for the identification of high prevalence geographic clusters within our community. In this case, it was Central Alabama. So the question that I raise is, could these high prevalence geographic clusters, if analyzed for the younger hepatitis C cohort, predict perhaps the next outbreak of HIV, or better be used to guide the location of community interventions aimed at fighting not only C epidemic, but also the opiate, injection drug use, and heroin epidemic. So I'm going to end there. I told you some of the exciting news that we've seen from the ED, and I'll let you introduce Doug White, but Dr. White's going to explain probably what's of great interest to all of you, which is the challenges and barriers to emergency department screening. And I thank you with that.
Great, thank you very much. And before I introduce Dr. White, I just want to remind participants you may enter questions into the chat function or email tbroder@nvhr.org. We will have time for question and answers. Today is Dr. Doug White. Dr. White is Associate Clinical Professor of Emergency Medicine at University of California, San Francisco, and works as an attending emergency physician at Highland Hospital Alameda Health System in Oakland, California. He serves as the Director of Emergency Department, HIV and Hepatitis C virus screening, residency education for emergency medicine. Since 2004, Dr. White has been actively involved in public health research with a focus on implementing models of HIV and hepatitis C screening in the urban emergency department. He is currently a co-investigator in an NIH-funded randomized controlled trial evaluating 3 HIV screening methods in emergency departments and recently began a hepatitis C screening and diagnostic testing program at Highland Hospital. He has developed a multidisciplinary collaborative network of hospital-based leaders from emergency medicine, laboratory medicine, and gastroenterology to develop testing protocols and linkage to care and follow-up procedures. Over the past 2 years, Dr. White's team has integrated both targeted hepatitis C screening, risk-based and burst cohort, as well as universal screening into emergency department clinical operations. Thank you, Dr. White.
Thanks for that introduction. It's a pleasure to be part of this panel and speaking with you all. Next slide. So I'm going to tackle the challenges and hopefully discuss some of the kind of real world and practical solutions to integrating HCV screening into emergency departments. The 3 areas I want to focus on are how best to complete the continuum of care cascade for patients. I want to discuss the barriers and solutions to dealing with the cost of setting up and maintaining one of these programs, and then discuss how to set up kind of the best or ideal screening model and discuss the challenges and practicalities with that. Next. So the HCV screening continuum of care, this is a public health model that is used to take a bird's eye view at kind of the efficacy and outcomes of a screening program. And it looks at it from the patient perspective and the program perspective. And it starts at the beginning of integrating testing and screening into ED processes, identifying patients who are antibody reactive, drawing blood, confirming that they are in fact chronically infected through RNA testing, making appointments, linking them, getting them on treatment, and then assessing whether or not they're cured by evaluating 12-week viral load response. This is the continuum of care model that we as practitioners that are integrating public health screening programs really need to look at the long-term outcomes of what we're doing. And you can imagine this is challenging. Next slide. So this is combined data from Highland as well as Alabama, where we looked at 6 months of our screening programs, and we followed patients who were identified Hep C antibody positive, and we followed them for a minimum of 12 months, all the way out to 18 of them, to see how they fared looking at it from this continuum of care perspective. And just looking at this slide, you see that there's obviously drop-offs at of the continuum. And what I want to demonstrate is that despite the significant drop-offs all along this cascade, the magnitude of the drop-offs mirror what is experienced in primary care and ambulatory care settings. When we actually believe that a patient identified in the ED is going to struggle with this continuum more than a patient who's identified, say, by a primary care's office. So even though there are drop-offs, there are definitely successes as patients move down this cascade. Just starting at the beginning, we had 532 newly identified HCV antibody positive. 80% of them had viral load testing performed. 70% of those were identified as being chronically infected and amenable for referral for treatment. We arranged follow-up in 50% of the chronically infected patients. They attended 60% of the appointments that we made for them. And of those patients who made it to a follow-up appointment, one quarter of them actually had treatment initiated And of those patients who were treated, 80% were essentially cured using 12 SVR as our outcome measure. What is not kind of appreciated when you look at this cascade is how long it takes a patient to move through the cascade. And that's what this next slide shows. So looking at the time it takes to complete what I believe are kind of three critical elements of the cascade. Number one, the time to the RNA completion, so the time to get that viral load drawn. All of our protocols were set up with the intent of having a viral load performed at the index visit, at that ED visit when their antibody test was reactive. But in reality, it didn't happen as much as or as often as we wanted. So this is looking at the subset of patients who did not have a viral load drawn during their ED visit, both at Highland and in Alabama. The median time to getting an RNA drawn for that antibody-reactive patient was 103 days. And looking at the median time for getting a patient into their follow-up appointment that we scheduled, median was 145 days, out to as far as a year in many cases. And lastly, looking at the time to actually initiate treatment, this is from their diagnosis being antibody positive all the way up to getting them treated, a median of 271 days. So basically, this is just a reminder that diagnosing them in the ED is kind of the easy part, and it is a marathon completing the different and various steps of the cascade. Next slide. So I want to discuss the challenge of completing the test algorithm. And what I mean here is, essentially, if you diagnose a patient who's antibody positive out of the ED, how do you ensure that all of them get an HCV RNA ordered, performed, treated by the... As you can see on this slide, you have to confirm chronic infection with HCV in order to link patients to care. Otherwise, there's no specialty clinic or referral provider that will take patient, especially into a Hep C clinic, who's not confirmed viral load positive. And we set up our program at Highland. We initially started with a stepwise algorithm whereby if a patient tested antibody positive, the lab kind of treated that as a critical lab value. They called the charge nurse notified the doc would then order the RNA test, and then the nurse would have to draw a separate blood sample and send that to the lab. Next slide. But the problem is, in 60% of our patients who tested antibody positive, that's 60%, we failed in obtaining that viral load during the index visit. And there was a number of reasons why our stepwise algorithm failed, but the number one reason was half of our patients were discharged before their antibody test was even resulted in the EMR. So having this stepwise system where the patient had to be informed, you had to separately order and draw blood, was essentially prohibitive. That meant that we had 60% of our patients we had to track down after the fact to call, arrange a way to have them come back, have a viral load test sent before we could do anything. Next slide. So there are different ways to kind of work around this problem of maximizing the proportion of patients who have a viral load sent during their ED visit. And what we did as our kind of initial solution was we created these screening packets whereby, and we placed these at all of the phlebotomy stations. So if a nurse was drawing blood as part of our screening program, whether it was HIV or hepatitis C, in that screening packet was an extra large tube, see the large lavender tube there in the middle, that would be drawn, filled, and then held by the laboratory in case confirmatory RNA testing needed to be performed for that subset of patients that tested who tested antibody reactive. We changed the EMR to prompt the nurses to utilize the package and draw the full complement of tests. We also added in physician precautions. We fortunately have lots of recidivism at the Highland patients over and over again. So what we set up was a system that would prompt physicians that if a patient came back to the department and had a gap in their cascade, meaning needed a viral load sent or needed appointment scheduled, it would prompt the physicians to kind of close that gap. So many of our viral loads were ultimately obtained kind of through that precautionary setup. But these are all kind of homegrown workarounds. These are not the long-term sustainable solution. Next slide. I think the only way to solve this completion of the test algorithm and essentially maximize the number of patients that complete that important stage of the cascade is to have automated reflex load testing built in to laboratory processes. This seems easy to do, and it should be easy to do, but there are a host of challenges that prevent labs from setting up this automated system. The ideal setting, the blood gets sent down to the lab. When the lab identifies an antibody reactive test, the system will automatically take that blood and perform an RNA testing. That is doable, but there are challenges. As you heard in one of the earlier talks, many departments are utilizing automated analyzers like the Abbott Arc. And there are problems with cross-contamination. It has to be handled, has different specimen handling requirements than the antibody test. Most often this is going to require 2 blood up front, but with a lab director and a computer programmer and some time, you can automate this system to make reflex viral load testing possible, and I do believe this is required for any program moving forward and setting up a program. Working to get a reflex system in place is critical, and it's taken us close to 2 years to achieve this process, and hopefully next month we will be rolling out an automated reflex system. Next slide. The next challenge is obviously linkage to care, and I've already told you that linkage is predicated on completing the test algorithm, and I've provided you with, I think, is the ultimate solution to helping with that step. The other challenge that we have with HCV that we don't, and kind of historically didn't have with HIV, is that we're talking about incredibly high numbers of patients that need to be linked to care. With our current model, we're identifying 1 to 2 HCV antibody positive patients a day. And I know that this is essentially mirrored in the other sites that are doing universal testing. Combine this with extreme limitations to capacity for treatment. For the first 1.5 years of our program, we had 1 half-day Hep C clinic opening. So we had a mid-level provider who essentially allowed us to overbook into her clinic. So we had wait times of 6 months, 8 months to link a patient to care. So you have this perfect storm, high numbers of positives and nowhere to send them, being the general overarching challenge to getting patients into care. The other problem that we found is even when we were able to make an appointment for a patient, they didn't show. And there's lots of reasons why this may be. Some you could blame on the fact that these appointments were so far downstream that it just fell off the patient's radar. But the reality is our patients have challenging lives. Many of them are uninsured. Majority are under, make follow-up challenging. They're phoneless. They have drug problems, alcohol problems, psychiatric illness. It's not to mention, a host of medical comorbidities that in many cases just kind of take precedence to Hep C, which is a diagnosis that most patients don't have a real good grasp and understanding of what that means, let alone that there's potential cure for them. These are all of the challenges that go into linking patients. Next slide. So the solutions, as much as I want to concede to this, because I've always tried to design models that could be integrated 100% utilizing existing staff and resources, I do believe, and I think most of my colleagues would believe, that the Linkage Coordinator, a full-time, dedicated staff who works to link patients to care, is required. The burden of patients that need follow-up and linkage is too great to be absorbed by existing staff. And this Linkage Coordinator is going to be in charge of, insurance enrollment. They're going to be doing heavy-duty case management to complete the test algorithm, and just numerous phone calls and surveillance and linkage. What we have found has worked, and some refinements that we've made in the last year is all patients who are antibody reactive, who are identified through our ED, just get referred right off the bat to our linkage coordinator. And that linkage coordinator essentially serves as kind of this centralized treatment referral person who's now looking at partnering with community members, primary care providers, as well as specialty clinics to link patients out for care. And this partnership with the community providers, I cannot, I have to just reiterate, this is such an important concept that you have to look beyond the Hep C treatment providers in order to kind of tackle the burden of disease. Next slide. Next slide. So when we first started, I told you, we operated on a half-day clinic at Highland only, and we realized that we, basically exhausted that capacity after a month of testing. So we essentially made a roadmap. We identified every primary care clinic and FQHC, kind of referred patients to our ED, and we essentially reached out to every single one of them. We found out who had capacity to treat Hep C, who was building up capacity to treat Hep C, who had linkage people that we could meet and talk to and have open lines of communication. And by doing this and actually setting up like bi-monthly meetings with staff at these clinics, we've expanded our referral network several-fold beyond the small Hep C clinic that we started with here at Highland. Next slide. Now on to cost. Now there's three main costs that you have to take into consideration. There's the screening costs. Who's paying for the screening tests? Then there's the programmatic costs. I've already said that a linkage coordinator, you have to figure out how to pay for a full-time linkage coordinator. And most of these programs have a dual HIV testing model going on as well. So having some sort of program manager in addition to linkage staff is probably necessary. So you're looking at a minimum of 1 to 2 FTEs to make one of these programs, to get them up and running, do the training and the ongoing in-servicing and the surveillance and linkage that's required. Now, I'm not going to touch on the challenge of paying for treatment. That is a talk in and of itself. Next slide. So in terms of paying for screening, because this is a barrier that comes up when you're trying to integrate Hep C screening into the emergency department. Now, prior to 2013, access to HCV screening was limited, in part due to costs of screening, but mostly due to the fact that this was not reimbursable by insurance companies. And there has been a definite change in the reimbursement for Hep C screening, and this is partly due to the healthcare reform and the Affordable Health Care Act, which, in 2013, with healthcare reform, not only did millions of people now have health insurance, but the Affordable Health Care Act essentially mandated first dollar coverage for preventative healthcare services. Now, this included all U.S. Preventative Service Task Force recommendations of grade A or B, and it was around that time that the U.S. Preventative Service Task Force actually evaluated the CDC recommendations for expanded HCV screening to the baby boomers, one-time, lifetime screen, and for those who had risk. So now you have this perfect environment of expansion of healthcare reimbursement, including reimbursement for Hep C screening according to the U.S. Preventative Service Task Force. Next slide. The following year, the Centers for Medicare and Medicaid essentially approved coverage for HCV screening. They said, yes, if you screen according to these U.S. Preventative Service Task Force, which were more or less in line with the CDC recommendations, we will pay for Hep C screening. The problem is emergency departments were explicitly excluded from reimbursement. The CMS really designed their reimbursement strategies around paying for integration into primary care. This was, in their eyes, kind of designed to be integrated into an annual wellness visit as part of a comprehensive prevention plan. The EDs were essentially left out of this despite all of the evidence that you've seen showing that the emergency departments fill an incredibly important niche in identifying disease in a subpopulation of patients that may not otherwise be identified. So this is a major barrier as programs move forward through HCV screening in EDs. Next slide. So how do we get around this barrier of screening costs? I think obviously this is where policy change needs to happen to extend CMS coverage beyond primary care into these secondary care settings that have demonstrated the capacity, the ability to diagnose disease and link them to care. So I think that is necessary over the next year or two. And then on a more kind of individual medical center kind of systems scale, essentially medical centers are going to have to absorb the costs of screening. There's really no other way around it. And at Highland, we have managed to demonstrate that this is clinically important. We are filling a public health service through our ED provision of HIV and Hep C testing, and our medical center identifies that this is valuable, and the laboratory essentially absorbs the cost. And we have had no difficulties at a relatively poor inner city struggling medical system to integrate screening. Next slide. The last challenge that I want to talk about is how to best develop and implement a screening model. And everyone wants to pick that one-size-fits-all model that satisfies everyone. And the reality is that's probably impossible to do because you're trying to balance competing priorities. I mean, ideally, we want to design a program that maximizes the number of our patients who get screened. Yet, at the same time, we have to integrate this into ED processes. We have to make our program simple and easy and sustainable. And the impact on ED services, meaning it can't slow down triage. It can't hold up discharges. These are essentially all requirements for designing a program and very difficult to check off all of these boxes. The other challenge is we are provided screening guidelines, right? The CDC, the U.S. Preventive Service Task Force, they tell us who to screen. The problem is these are not intended for an emergency department. They're actually fairly impractical to integrate into the ED, especially if programs are trying to layer on hepatitis C screening, say onto a department that's already doing some HIV screening. All of a sudden we have different age categories. We have HIV for this group, and now Hep C, we have to ask age and injection drug use risk, and it just essentially adds a cumbersome element to the program that essentially leads to kind of staff burnout and lack of buy-in. I think this is another reason to support this concept of universal screening. You could now adopt a universal screening policy for HIV and Hep C that essentially has the same eligibility requirements for your screening pathway. Next slide. So this is my final slide, and this is kind of my solutions to developing this best or ideal screening model. I think number one, you have to streamline this process. You have to trim out every unnecessary step in order to make it integrate as seamlessly as possible. Utilizing the electronic method, making sure that the EMR can exclude patients on prior testing, on prior known diagnosis of disease, automating the ordering process are requirements. And obviously, you will have to make concessions. Trying to balance the goals of a public health HCV screening with the primary mission of an emergency department, which is to provide acute medical care, that is challenging, that is difficult, and you will have to essentially win some battles and lose some battles and make concessions along the way. You should look around your ED and figure out what resources you can leverage, understand and respect that competing priorities are part of this process. And lastly, there is no gold standard. What works in Alabama and what works in Baltimore may not be the model that is integratable and sustainable at Highland. And I tell everybody that wants to set up a program, any test is better than no test. Thank you.
Great. Well, thank you very much. And thank you to all of our presenters. That was an extremely fascinating presentation outlining the critical role of emergency departments in hepatitis C screening and linkage to care, the challenges that they face, and potential solutions. So we have some time for questions. I want to remind everyone you can send questions to the chat function or emailing Tina Broder up on the slide how to do that. I know that we're getting a number of questions, and so if we're not able to get to all of them in our remaining 20 minutes, we will do our best to make sure we get them answered offline and sent to and asking the question. And we are getting some questions asking if slides will be available, and the answer is yes. We will be sending a link to the presentations and the recording to everyone who registered, and it will be available on our website. I have a quick question around the CMS issue. That's certainly an issue that advocates are aware of. We were excited when CMS announced the coverage determination for hepatitis C screening, but disappointed in the limitation of primary care, and certainly hearing how that's a challenge. But I do want to ask, since that the CMS determination was specific to Medicare, and you indicated many of your patients are Medicaid patients, are you finding the same limitation for your Medicaid patients?
Yeah, it's actually very hard for us to figure out who is getting paid for what. In discussing with actual people from CMS, they really don't, they are essentially saying the ED shouldn't be doing it, and they're very clear on that. And the other problem that we're running into from the ED reimbursement strategy is these screening tests, we aren't linking an I-10 diagnostic code to the actual test that's performed. That's just part of how our ED billing works. So it's possible that even if CMS would reimburse some of these tests, we haven't set up the program to even maximally capture any reimbursement. And that's just how our ED reimbursement works for individual lab testing. So there may be work that could be done on our standpoint, but our understanding is basically tests coming out of the ED, they have no first.
Sure, that's very helpful. And I'll also note that some research was done because hepatitis B screening is about to receive its determination with the same limitation, and we learned that the HIV coverage determination by CMS does not limit to primary care, and in fact talks about the many points in the healthcare system where HIV, where people enter the system, and therefore screening should happen in a variety of venues. So we're hoping to get that change for viral hepatitis. So Tina, I'm going to turn it. Oh, go ahead, please.
No, I'm sorry. This is Jim Galbraith. I just wanted to add one thing and reiterate what Doug said. The question would be, can a health system absorb basically what is a $5 test onto a patient visit? And the real challenge that we have here at UAB is we're performing high volume testing. So when I say high volume, we will test over 20,000 unique individuals this year, and we're doing it in real time. And there's labor required to perform these tests, and these are not a routine common test that's performed 24/7 on demand in the hospital. So in order to implement some high volume screening, you actually do need some sort of money coming back in to your program to support just the laboratory effort, which is significant, that's required to get these results back during the time frame of an index ED visit. And I'll end with that.
Great, thank you. That's very, very helpful. I'm going to turn it to Tina, who is receiving questions.
Great. Thank you, everyone. This is Tina Broder, and I'm going to attempt to bundle some of the questions that we've been receiving, and many of them are asking about cost. So I'm going to sort of give a couple of intertwined questions. Someone asked if the linkage coordinators are also covered by these grants, who's paying for these programs, and have you considered 340B or other mechanisms to support financing these screening initiatives?
So this is Doug speaking from Highland. Our Linkage Coordinator, our program is essentially funded through a grant through Gilead Sciences. So we receive money that pays, so the Gilead money goes to a full-time Linkage Coordinator and a full-time program coordinator. This allows us to do both HIV and Hep C screening. All of the costs for testing are essentially absorbed by the hospital. Regarding the 340B pricing, our hospital is currently in contract to get 340B pricing, and that is the tool that we are leveraging to essentially make this program sustainable. And once that is achieved, we should be able to fund our program without any problems long term. There's already talk about our Hep C clinic using 340B reimbursement for a clinic-based linkage coordinator at Highland so that they don't lose the patients that we're now referring back to primary care. So this 340B pricing is a major incentive, and I do believe this is the only incentive that will work to make these programs sustainable and hire the necessary staff.
This is Rich Rothman from Hopkins. So we have a very similar mechanism to Dr. White currently, in that we're supported by Gilead Sciences, and I think the sustain pieces can't really be underestimated in any way. And the only venue I've seen so far is the 340B. We're exploring that as well, but I think that there are challenges with navigating where exactly those funds go to, but I think that's our lowest hanging fruit in terms of identifying a sustainable mechanism as well. I think the issue of changing regulations and some of the legal aspects of reimbursing testing costs in the ED should be pursued as well, just as it was for HIV, where initially many of the ED testing sites had for HIV testing either through startup projects with the health department or through other private entities, and now there are clear mechanisms reimbursing in the ED, and I think that's an important route to go for HCV as well.
Yeah, for the UAB side, we're funded by Gilead Sciences as well. That includes the cost of our testing and linkage to care. We're currently exploring the 340B option, but it is difficult to know where how that money will be redistributed to support ED testing. And I will also agree with what Dr. Rothman said, is initially our HIV screening program as of 2011 was supported through funds that were coming from the CDC and Department of Public Health to cover all of our costs of ED testing and confirmatory testing, and now to date we're successfully billing for those services.
Thank you. I'm now going to bundle up about the mechanism of testing. So one was, where does the architect sit? We don't have space in the ED for this. Another asked around the challenge of reflex testing, whether had considered using rapid kits and then drawing blood for the reflex test so you don't have 2 tubes. For those of you drawing 2 tubes, did you receive consent for the extra tube of blood?
Well, this is Doug White talking. In terms of the algorithm of doing rapid tests followed by confirmatory viral load, our days of doing rapid tests point of care are essentially over, mostly because of the quality control issues around doing that point of care at the bedside. It was just too hard to sustain, and our lab really wanted to do everything herself in the main hospital lab. So at least for most EDs, I don't think they're breaking it up, kind of bedside rapid test followed by venipuncture. The architect is housed in the main centralized hospital lab. We just tube our specimens down, and then we don't consent for a separate blood draw at all. Essentially, from the patient perspective, the blood's being drawn as part of their screening test.
Yeah, here at UAB, we, back in 2013, installed the Architect instrument, which, for those that aren't aware, it comes in the I-1000 and I-2000. And the I-1000 is what we have. It's about the size of a large copy machine, and it is very hard to fit in a setting where you have limited space. We're fortunate at UAB to have an emergency department lab, and even then within that lab, space was limited, but we were able to fit it in there, much initially to the protest of the laboratory, but who's now running all the tests. But we've been very, very happy with the performance of that instrument.
So this is Rich Rothman from Hopkins. Just I want to add one point in terms of we do blood-based testing as well using a laboratory-based instrument. What we found at Hopkins over the years with our HIV testing program is that our model for reaching the maximum portion of the population as we're able to, is that a hybrid model worked well. We have support for the health department for HIV testing staff, and point of care testing continues to work well for those individuals who aren't getting blood drawn for other reasons. And so I think there may be certain venues where a point of care HCV test could have that added value of, you know, getting the result right then and there, right at the bedside, and then being able to reflex without an additional tube of blood coupled at the initial time. So we're looking into developing and piloting a model for that.
Thank you. And can you comment on how your different sites have used EMR algorithms to facilitate screening? And the person asking the question was also curious about how and if you were able to obtain SVR data for those screened in the ED, assuming those patients got treated at different locations, or was there SVR data you weren't able to obtain?
I'll talk about that. Oh, go ahead, Jim.
All right. For our emergency department, for the first question, our EMR, the way our automation is performed, the nurses have required questions that occur at the triage process when the patient enters the emergency department. That includes collecting things like chief complaint, address, other registration information. But again, this is collected by a nursing provider. But one of the required questions, and we simplified our question process, is, have you ever been diagnosed with hepatitis C infection, yes or no? And if the answer is no, the nurse provides an opt-out statement that goes along the lines of, we perform routine hepatitis C virus testing for all department patients annually. One will be performed today unless a test result is within our electronic health record within the last year, unless you wish to decline. I didn't say that very eloquently, and it's certainly worded a little bit different, but the long story short, if the patient doesn't decline the test, which we see about 25% of our patients actually do opt out or decline, then on one click, the electronic health record automates an order for the hepatitis C antibody test, and the electronic health record checks to see if a prior result is present, positive or negative, and if one is, in the last year, it cancels the order for the Hep C screen. In relation to the SVR data, and I think Doug can elaborate on this a little bit, we are only able to see data within our health system. At UAB, we do have the challenge that many of these patients can go anywhere to other community hospitals to get treated. So our data is limited only to those that followed up within our system. But knowing the capacity of other services around central Alabama, we suspect that we're identifying the majority of those individuals that would have been treated and obtained SVR.
And did anyone else want to speak to that? Or should I?
No, I mean, more or less I agree with Jim. The data that I presented, at that time we were only referring to one clinic. So that was, at the time, the best SVR. That was fairly reasonable SVR data. Now it's much more complicated as we are farming patients out to a variety of clinics. Following up them longitudinally is much more challenging.
This is Rich. One thing about the EMR builds, I think the value of EMR builds can't be understated in terms of streamlining processes for integrating, any kind of screening into the emergency department. And I think each of us has had experience over the past, 3 to 5 years, which was totally different from what it was 5 years ago when we were trying to do screening without without all of the bells and whistles that are now provided by some of the large EMR capabilities. And so I think moving forward, some of these builds could be shared across sites that may help other sites be able to integrate testing in a streamlined way. And some of the processes associated with building those EMR setups for each individual site should take into account integration with the peculiarities and specifics of nursing and physician flow at each ED.
So I think this will be the last question I asked. We had some questions of how your hospital health systems responded. Did they consider it an important endeavor? And do you have any advice for folks working in the community who wish to approach their local emergency departments about initiating screening efforts?
I'll start. This is Jim Galbraith from Birmingham. C, it was easy to engage our institution, having already broken some of the barriers and changed culture related to HIV testing in our emergency department. And the results of that testing being very, very positive or well received amongst our institution as well as the ED providers really facilitated the addition of hepatitis C testing. Engaging in emergency department itself is challenging, and it depends on the emergency department that you're trying to engage. Many are facing a lot of competing priorities and are working at full capacity, or sometimes are understaffed to already handle the needs that are required, and you're asking to add one more thing on. The key to this is identifying a champion at each emergency department that you're looking to initiate testing. And I believe those that are led, whether it's provider or an ED provider within those EDs, I believe having a champion at those sites is essential to having a program and getting the buy-in from other providers. Ultimately, anything you can do to take the ED provider or nursing provider or limit their burden of the process will facilitate testing.
Thank you. So I'll turn it back to Ryan to close our webinar. We do have some other questions that we didn't have time to respond to, but I will share them with the panelists, and we will provide a summary on our archive of the webinar or connect people individually. If you have other questions, you can go ahead and email me directly, and I can put you in touch with the panelists. So turning it back to Ryan.
Great, thanks, Tina. And as Tina said, we will do our best to make sure everyone are answered. I really want to thank our panelists. Again, I found this to be a very informative presentation. I learned a lot, and we have a lot of advocates on the line, I know, and you've provided us with a lot of information on how we can some solutions with you from an advocacy perspective. I also medical providers and public health representatives on the line who I'm sure found information extremely useful. So with that, I want to thank you again. I know you have very busy schedules and appreciate your to share your experiences with the group, and want to thank all of our participants. From what I could tell, this is one of our most popular webinars to date, so the topic was very relevant and timely. And thank everyone for being on the call and webinar today. And for feedback, and if you want to be connected with the presenters, we will do our. So with that, have a great rest of the day and week, and get that information out to everyone. Thanks again, everyone.